Great. Thank you, Chantry. So good morning or good afternoon, everyone. My name is Kendra Unger, and I am a professor in the Department of Family Medicine, and I am also the Vice Chair of Education. And I'm really happy to be here today talking to you about interventional procedures for non-cancer chronic spine pain. What I'm going to share with you in this discussion today was very shocking to me, actually. This is something that I treat every day in my acupuncture clinic as well as my family medicine clinic. I'm also a board certified medical acupuncturist, so I see a lot of patients with this type of spine pain. And I was actually really surprised by some of these guidelines that I reviewed during this paper. And I'm really excited to share this with you because it may have implications to change the way we're practicing in our own clinics. So the paper that I'm referring to today is listed here. This is a rapid recommendations published by the British Medical Journal earlier this year in 2025. The patients that this paper is referring to are those with chronic axial and radicular spine pain that is not associated with cancer or inflammatory arthropathy. So this is chronic pain, so it needs to be present for 3 months or longer, and it needs to be present for over half of the days in the patient's life. This is not associated with cancer, so obviously not due to any mets to the spine. And it's also not due to inflammatory processes like rheumatoid arthritis or ankylosing spondylitis. This also is not referring to acute spine pain. So I hope that helps you wrap your mind around which patients we're talking about. We're talking about those chronic spine pain patients that we're seeing every day in our clinics. So how big is this problem? Most of you joining us here are from family medicine, so I don't need to tell you how big this problem is. We see these patients all day, every day. And this is prevalent in about 20% of adults aged 20 to 59. So that's a huge amount. 39% of people have experienced chronic axial pain of some kind. And I can say that I'm one of them. And this is a very difficult thing to treat. This is the leading cause of disability worldwide, which is an amazing problem. And neck pain is the third in cause of disability years lost in the world. When this paper was published, they used some data from 2016 to talk about the monetary effect of this, and it exceeds $134 billion. So we know that this problem is very prevalent, and we are seeing this a lot in our clinics. So how do we treat chronic axial spine pain? So this is an NIH stepwise care approach to patients with chronic lower back pain that was developed in 2013. And this is what I've been using in my practice primarily to manage our patients. So you can see here in step one, we are talking about non-pharmacological treatments. Of course, acupuncture is listed first, but also yoga, heat, exercise, manual therapies, and other types of therapies are listed. If you notice, step five is where we're supposed to be considering medications. But I'll be honest, as a practitioner, I bring step five down to step one, honestly. So when I'm seeing a patient for chronic spine pain, I'm thinking about medications and non-pharmacologicals at the same time. Topicals are step two. So those are things like your diclofenac gels, your lidocaine patches. It's not until step three and step four where we start to consider injection. And that is what we're talking about today. These are the interventional procedures that we're going to be discussing and their efficacy and safety. And then step six would be surgery, which is beyond the talk of the scope, but I think we all agree that that's our last ditch effort. So when we're talking about these interventional procedures, how many are we doing? And it turns out we're doing a lot. Okay, so epidural steroid injections increased in their use by 271%. between the years of 94 and '01. That is a huge increase in interventions. Also, facet joint injections also increased by 231%. And when you look at Medicare data for these particular facet or SI joint injections, it exceeds 2.2 million. And so the point here is that our patients are suffering from this type of pain, and we are doing these injections quite frequently to treat this. So the reason that the authors of this paper we're discussing today decided to really do a deep dive into the literature is because there are a lot of conflicting recommendations out there for chronic axial and radicular spine pain. These are two examples. If you look at the American Society of Pain and Neuroscience, they have a strong recommendation in favor of epidural injections to treat this type of pain. But if you look at the American College of Occupations and Environmental Medicine, they have recommendations against this type of intervention. And so, who do we go with? There are many other conflicting recommendations, and if you have a chance to sit down and read this paper, they list some of the conflicting recommendations from major organizations throughout the United States. And it's actually a very interesting read. And so the goal of this group was to really do a deep dive and give us some good clinical recommendations based on the literature that's out there. The way that they did this is they created an international panel. And this international panel was made up of 10 clinicians, and I've listed their specialties there. The interesting thing about it is that 6 of them had had experiences with these interventional procedures, whereas 4 of them did not. They also included methodologists to help them make sure that the way they were analyzing this data was efficient. But the thing that I think makes this paper stand out and actually makes it an excellent paper is that they actually included patients in their panel. They included 4 patients who all have chronic low back pain. That should actually say chronic spine pain. 3 of them had had interventional procedures and 1 of them had not. 2 of them had reported some benefit. Now, you're probably thinking, okay, there may be some bias injected here, right? Well, all of the people who participated were carefully screened to see if they had a bias for or against these procedures, and it was found that everyone on this panel was neutral. Okay, so they didn't have a bias for or against the procedures. The other interesting thing that they did that they looked at here is they utilized a grade approach. So the grade approach provides a transparent and structured framework for evaluating the certainty of evidence in systemic reviews. This is to ensure a consistent method for grading evidence quality and making recommendations. So they utilize this throughout their procedure. They also required an 80% consensus among panel members to make a recommendation. And they also used the Magic Evidence Ecosystem Foundation, which is a foundation of clinicians and evidence-based medicine experts on a mission to improve patient care globally by enhancing the creation, dissemination, and implementation of trustworthy guidance. And this is a nonprofit organization. So I feel that these folks did their due diligence when creating an excellent panel and using evidence appropriately. So what did they look at? So on the screen, you will see box 2. I took this directly from the paper, and these are the different procedures that they looked at. They looked at 13 different interventional procedures that ranged everywhere from epidurals to joint targeted injections to root ganglion to radiofrequency nerve ablation. So the very common procedures that we are recommending for our patients. This was a meta-analysis that took into consideration 81 trials from across the world involving around 8,000 patients. They also looked at patient outcomes, which included, of course, pain relief, but other things that patients identified as important, like functioning in their jobs, functioning in their homes, the use of opioids, how well they're sleeping, and other adverse events. So I absolutely love this special piece to this paper. So the patient population, I'll remind you again, this is the population we're looking at. Adults with axial and radicular pain. It can be cervical or lumbar, and it must be chronic. This does not include acute spine pain or other cancer or inflammatory related pain. And these are the patient values and preferences that these recommendations are based upon. And so they looked at cost and access. So typically when a patient is undergoing one of these interventional procedures, it is repeated quite frequently. Our patients getting their spinal injections, these injections are done every 4 weeks, 6 weeks, 8 weeks, 12 weeks. So the patients are coming back over and over again. As you'll see later, an epidural injection can cost $1,000 to $5,000 a pop. Okay, so they're looking at cost and access. So they're taking into account as well the amount of time missed from work, the amount of downtime it takes to recover from these procedures as a cost and an access issue. They also took into consideration adverse effects of these interventions, such as a deep infection or temporary altered consciousness. And then there are very small risks of catastrophic harms that were documented, such as paralysis or even death. They also took into considerations values and preferences. And what they found is that patients are willing to undergo these procedures if there is a moderate rate of success with low risk of harm. I think we could all agree with that, right? They also found that these patients found that this was unacceptable if the benefit that they got from the procedure was minimal and the risk was high. So again, I agree with these patient values and preferences and think that it was pretty well thought out. So get ready for the drum roll, because here comes the recommendations that are just going to blow your mind, because they blew my mind. Okay, here we go. This panel gives a strong recommendation against pretty much every intervention that we are suggesting for our patients with chronic axial spine pain. Whoa. Okay. Whoa. So they are recommending against epidural injections, joint radiofrequency ablation, joint targeted injection, intramuscular injection, dorsal root ganglion injection, and epidurals. Oh my gosh. So if you're like me, I was reading this and I said, wow, this is going to dramatically change how I think about this problem. Because as part of my workup, I'm assessing and referring these patients to our pain clinics who are doing these procedures. And when I'm looking at this, I'm a little bit panicked, right? Because my gosh, that's completely against what I've been doing. So I decided to push pause and I decided to phone a friend over at our local pain clinic here in Morgantown. So I phoned a friend, and this is an anesthesiologist that I called who works with these interventional procedures. And I sent him this paper and I asked him what he thought and what his thoughts were on this. And his response to me was, if they don't work, then why is my waiting room always full? Now, I think there's some truth to this, right? Because patients often don't come back if something doesn't work. But I think his waiting room is full because the problem is so huge, especially when you look at our state, when you look at West Virginia, look at the prevalence of chronic spine pain in our area. It's huge. So the waiting room's full because the problem is a big one. He also said that RCTs for injection versus sham for every diagnosis is not feasible. That's also a good argument. However, I am a strong believer that you don't need sham to show efficacy and low risk, right? So, because I practice acupuncture, it's darn near impossible to do sham acupuncture, right? So I use my reasoning there that you don't always need a sham to show that something works and that it's safe. And then he also cited pressures from socialized medicine to cut cost. He's right. These procedures are very expensive, and we are always looking for something that is more cost effective. However, when you look at the global system of medicine, a lot of them are focused on cutting cost, and this is not necessarily should not be taken into the equation. I feel like these interventional procedures are highly costly for low benefit, as what we're seeing here in this discussion. So he directed me to, think about my patients, think about how we can help them best, and to refer to my guidelines through the AAFP. And I thought that was great advice. So, moral of the story, I do not think that these new recommendations, unfortunately, are going to change how our chronic pain clinics are managing this. But if you ask me, I really think it should. So I decided to do what all good family medicine doctors do and go look at the AFP. And what does the AFP say? And of course, I love how they said we should engage in shared decision making with our patients. Of course, we do that with every patient every time. So I agree with that. It's important to talk to our patient about what their values are and how we can be looking at those things. They also said that cognitive behavioral therapy shows modest improvement, so we should consider that. Another mind-blowing thing that they had to say, medications have limited benefit in low back pain. NSAIDs and duloxetine, aka Cymbalta, have the strongest evidence for benefit. And Tylenol doesn't work. That was also surprising to me because I am an advocate of Tylenol for these patients with, chronic spine pain. So something I learned today too, when compared with placebo, Tylenol is not effective. So really what I'm getting from this is we should talk to our patients, we should think about cognitive behavioral therapy, and maybe some NSAIDs and duloxetine. So how does the AAFP tell us to manage low back pain? I was actually shocked at this as well because they agree with these recommendations that I've just shared with you. So their stance is that few interventional procedures are beneficial for low back pain and that the radio frequency ablation does not show any clinically important effects, and it doesn't improve disability or quality of life. Epidurals only improve pain maybe by 0.75 on a 10-point scale, which is not really clinically relevant. And it does not improve patient functioning. Intra-articular joint injections are frankly not beneficial. SI joint, we don't know if they are. And spinal cord stimulation does not meaningfully improve back pain, leg pain, or health-related quality of life. Is anybody else blown away? I mean, I am just absolutely amazed by these revelations here. And this is what our organization is telling us about these procedures. So then I sat back and I asked myself, well, why are we doing them? If they're not effective and everybody recommends against them, why are we doing them? Well, I think the answer is the almighty dollar, right? So a single epidural steroid injection is about $1,000 to $5,000, depending on where you're having it done and what the cost of living is and where you're located and where your practice is located. So they're a big revenue generator. Another reason that I think we're doing them is because there is substantial reimbursement from insurances, despite the fact that the data does not back up their efficacy. Our insurance companies are paying for them. So Medicare providers increased by 13% from 2012 to 2016. I bet you if we looked at that number now, it'd be a lot bigger. I'll remind you of the increase of injections we were doing. And then interestingly, the top 10% of interventionalists in the United States, they perform 9 times more procedures than the bottom 10%. So some doctors are really cashing in on this and getting significant reimbursement. So I think that's the driving force here. So let's go back and look at our recommended treatment plan and talk about whether or not we should be doing these things. So step one, non-pharmacological. Sure, our risk of harm is low. Some of them have been shown to be beneficial. Why not? I say, and I think all of our guidelines tell us, yes, do those things in step one. Step two, topicals. Why not? Go for it. Use your gels, use your lido patches, do those things and see if it's going to benefit or help your patient. Step five, medications might help, but watch for adverse effects or lack of effect. Now we know that Tylenol is not really recommended. Surgery, beyond the scope of this talk, would love to come back and talk about it. But what about these injections? AAFP says no. Kinda. They say talk to your patient. But all of the recommendations that I've talked with you today say no. So I would like to open the floor up to questions regarding this study at this time. If you would like to ask me anything, if nobody has any questions, we can move on to some cases and see what those look like. But I hope this has generated some thoughts and some discussion because it really did for me.